That you're trying to keep people alive here, for crying out loud. You got cancer, you want to live. Most people want to live, and they're going to do whatever they can, but they go to their doctor thinking that he knows what's going on. 90% of the time, he has no clue. He has no knowledge about what's going on. He knows only what he's been trained to do. He doesn't know the biochemistry and the biology of the disorder that he's treating. And this is the tragedy. We have a clear plan for success. We're just not implementing it the way we should. The thing that we're trying to emphasize is that if you do metabolic therapy the correct way, you can not only manage the disorder, but you can also correct and fix many, many other problems that some cancer patients might have, like diabetes, high blood pressure, hypertension. So you actually get healthier as you're degrading your tumor. And I'm not saying we throw out all chemo, because obviously you folks have done really well with chemo. What we're finding with fasting and part metabolic, part chemo, what we're finding is that dosages of chemo can be lowered significantly and still have powerful therapeutic efficacy. If you want to live and you want to get healthy, you do metabolic therapy. Well, it's called the somatic mutation theory versus the mitochondrial metabolic theory. In one theory, the somatic mutation theory says that all cancers are caused by mutations in the nuclear genome. And that underlies the strategy for precision medicine and personalized therapy and these kinds of things. The other theory, the correct theory, the mitochondrial metabolic theory, says that the mutations are certainly there, but they're downstream effects of the damage to the energy producing organelle in the cell, which is called the mitochondrion. So a damaged mitochondrion will produce reactive oxygen species, ROS. These are carcinogenic and mutagenic. So the mutations that we see in many cancer cells or many tumors, all kinds of mutations, are downstream effects of the damage to the respiration. So what that means is that the cells can't get energy from oxygen. Cancer cells cannot. They can grow in the absence of oxygen, clear indication that they've got a real problem. They're using fermentation, which is an ancient pathway to get energy without oxygen. And we have interrogated all the amino acids and fuels that these cells can try to use. And all of our findings and many other findings from other investigators point to glucose and glutamine as the only two major fuels that can drive the dysregulated growth of tumor cells. And because they have that respiration defect, they can't use fatty acids or ketone bodies as an alternative fuel for glucose and glutamine. You need to respire fatty acids and ketone bodies. You need oxygen to get the energy. And tumor cells don't use oxygen. They grow in fermentation metabolism. So the solution, the pathway to the management of all major cancers, is to simultaneously restrict the availability of glucose and glutamine while transitioning the body to fatty acids and ketone bodies. And this way, the tumors are marginalized and destroyed without toxicity. So this will be eventually the standard of care. It's just going to take, I don't know how many years, because it's a disruptive technology. It's a disruptive concept, and it's not going to be taken lightly by the system, which is the hospitals, the pharmaceutical industries, and all of the current organizations that treat and try to manage cancer. Listen, when your life is on the line with a disease that could potentially kill you, it becomes important to become scientifically literate as fast as you possibly can. Otherwise, you could be swept away. So yeah, I understand some of these. What I get, the overview that I just gave you, is really a tiny snapshot of decades and decades of scientific hard research done in the laboratories. So, and I know it can be sometimes overwhelming for some folks that aren't working in the trenches like we are. But we try to do our best. And what I can do is attempt to answer any question in greater detail that might be necessary to convey the message. 6-deoxy norleucine, oxonorleucine.
Okay.
It's a molecule that looks very, very similar to glutamine, the amino acid glutamine. So, um, glutamine is an essential fuel for driving tumor cells, especially metastatic cancer cells. Um, Metastatic cancer cells that we have found in all major cancers have characteristics of macrophages, which is an immune cell in our body, a very powerful immune cell. Um, they naturally have the capability of moving in and out of tissues. They track down and kill bacteria. They help repair tissues and all this. Um, they are the metastatic cell. They have fused with either a stem cell or have become corrupted themselves. And we know from decades and decades of research that glutamine is the primary fuel for macrophages. So when we discovered that the metastatic cancer cells have all of these macrophage characteristics, the first thing we know from the scientific literature is what they eat. We know that glutamine is a prime fuel for macrophages. If most metastatic cancers are derived in some way or another from macrophages, then we know what they need to fuel themselves to grow, and that's glutamine. So that brought us to recognize DON as a potential drug that could interfere with the way glutamine drives the energy in the metastatic cancer cells, knowing that glutamine is a main fuel for macrophages and that metastatic cancer cells, for the most part, express characteristics of macrophages. So we were pleasantly surprised at how powerful we have a model of the best model of metastatic cancer, in a natural model of metastatic cancer. We were surprised at how powerful DON was in killing metastatic cancer cells. Then we looked further and went into the human literature, and many clinical studies had been done in patients with cancer over the years with DON, and it was taken off because they said it was too toxic. This drug and it was toxic in the mouse as well. But I met some guy from the pharmaceutical company, a big pharmaceutical company guy, and he said, if you have a drug that's really therapeutically effective but toxic, and you find a way to remove its or reduce its toxicity, then it becomes like a new drug, a new improved. In other words, you maintain the therapeutic efficacy while removing what was previously considered a toxic secondary effect. Well, we found that. We know that when we administer the drug under nutritional ketosis, the level of toxicity from this drug is massively reduced. So, if I were to have cancer, any kind of a cancer, brain tumor, colon cancer, whatever, I would be taking DON while in therapeutic ketosis, along with Fenbendazole, which is a very similar another drug that can target glucose and glutamine, but not as powerful as DON. DON is the big hammer. When you use DON, Fenbendazole, and ketogenic diets, you get the power of the dietary shift in the body, and you make the tumor cells extremely vulnerable to this diet drug cocktail. And our paper that we published recently in bioarchives shows how in pediatric brain cancer, the number one killer of little kids' cancer death is glioma, a high-grade glioma. And we have a very good model for high-grade pediatric glioma. And for the first time, we use this diet drug cocktail with DON and Fenbendazole and ketogenic diet. And you can look at the video in the paper. It's unbelievable. And it'll work just as well in adults. It'll work because we're targeting the very essence of what the tumor cell needs to survive. So they can't use ketone bodies and fatty acids. So they're supremely dependent on fermentation. And one of the fermentable fuels is glucose, and the other fermentable fuel is glutamine. And DON is interfering with the glutamine pathway and the ketogenic diet and Fenbendazole are interfering with the glucose pathway. So you put the two together and you have a diet drug cocktail that has the potential to successfully manage the majority of metastatic cancers. Problem is, Don is not available. It was taken off. And for all this talk about freedom to choose, or what is it called? There's names for these things that you should be able to. What is it? There's a name for this whole process. Right to try. I think that the term is right to try. The problem is you go and try to do the right to try Don, and you got massive bureaucratic paperwork, not only in your state government, but also in the federal government. Now, what's really disturbing is that Don was used on little kids with leukemia, and it did pretty well. The papers were published by Dr. Sullivan some years ago. Don was used against a variety of cancers. It wasn't used in the correct way. The dosages were too high, and they weren't using it under ketosis or with glucose targeting at the same time. So again, we have a tool that's available that will have a major effect on reducing metastatic cancer, and no one's able to get it. But I know I can buy it from chemical companies and things like this. I mean, I have access to this, but you wouldn't, and a lot of the physicians don't have access to it. That you can get it from China. The problem, of course, is it needs to be vetted to make sure it's not something that's going to kill you. We've tested a few of these things and it works. And of course, you don't think the drug companies know about this? So they're taking the Don molecule and they're trying to tweak it, add the structure of it slightly, so they can patent it and make billions of dollars. Okay, but it's going to be the same drug. It's not going to be any different. So one of the problems with this drug Don is that if you take it orally, stomach acid destroys it pretty quick. So we've injected it into the mice. Now, most chemo is injected by ports and things like this.
Yes.
So Don could easily be injected in a port manner, and the toxicity that would be experienced would pale in comparison to the toxicity that you'd get from that fire thing you were just taking. So hair follicles do not fall out of your head. Cancer cells do not hide in hair follicles, okay? So whenever you see a bald cancer patient, he's being treated by someone who really doesn't understand the biology of the disease they're working on, because cancer does not hide in hair. So why should you go bald? The issue here, Don is not going to make you go bald. Ketogenic diets aren't going to make you go bald. As a matter of fact, they may encourage hair growth. The issue is that most of what we're doing to treat cancer patients is not based on our understanding of what the tumor cell needs to survive. We're not targeting the very core essence of the viability of these cells. Without energy, the tumor cell cannot survive. The only way they can get energy is through glucose and glutamine. And Don targets the glutamine, and the diet targets the glucose along with Fenbendazole. So you're really putting a world of hurt. And you're transitioning the whole body over to ketones, which enhance the health and vitality of the normal cells of the brain and our other cells, but not the tumor cells. So as the blood sugar goes down, all of our normal cells now compete for that sugar, including the brain. And for the first time, the body is now competing directly with the tumor cells for a fuel that the body cells have the flexibility of using glucose and ketone bodies. The tumor cells are locked in to using only glucose and glutamine. So, but that body doesn't turn on the tumor cell until you lower the blood sugar to a level where the body starts to recognize that we're under a restricted condition here. And then if you keep that restricted condition long enough, which can vary from one person to the next, the body goes through a surveillance system. All cells in the body must now carry their own weight metabolically. So the autophagy, which is the internal eating of organelles to make the cells healthier and more fit to survive this new stress. The tumor cells cannot do this because the mutations that they have collected in their nucleus prevent the flexibility they need. The cells in our body are the result of millions of years of harsh evolutionary conditions that we have come through as a species, okay? These tumor cells have compromised and given up that because of the mutations in their nucleus. So what we're doing is simply transitioning the whole body over to a Paleolithic state, which is inhospitable for the tumor cells. And the body will actually turn on the tumor and eat it and use the fuel from the tumor cells to fuel the rest of the body once you get below the threshold, when the body starts to look carefully at who's not carrying their weight for the good of the whole. And this is an evolutionary concept. It's called autolytic cannibalism. And I wrote this chapter in my book on this. And the first time I saw it happen was with the dog that turned on his mast cell tumor and dissolved it. And the mechanism we turned was autolytic cannibalism. And I see so many people who have gone on these long water-only fasts to come out with no cancer. And what this is, again, the body is turning on the tumor and using it as a fuel for the rest of the cells. And you keep the pressure on these tumor cells, they can't survive. They've got everything going against them. They're not flexible. They got all these different mutations. They're locked into a fermentation metabolism. They've compromised their metabolic flexibility for the success of their dysregulated growth. So you have to, and again, I have just given you a summary of decades of research supporting what I'm saying. So it all makes sense. It all works, and it's all based on our understanding of evolutionary biology. And that's another thing. You got to understand evolutionary biology if you really want to manage cancer. People can say whatever they want to say, but this is part of the scientific literacy that will eventually be necessary if people want to know how, in fact, they can manage their cancer without toxicity. That's why you need the drugs, and because there's no diet that can suppress glutamine. It's the most abundant amino acid in our body. It's more than But what you can, what we found, if you do this fasting and do some good exercise, walking many miles and some moderate lifting, you can actually lower glutamine levels also. The exercise component, while fasting, will lower. My late good friend George Cahill, who was the president of the Joslin Diabetes Center down here in Boston, he did all kinds of studies on diabetic patients, and he was able to share with me many of his findings, which of course I've adapted now over to the cancer population. But he was able to show the transitions that normal cells can make from one fuel to another fuel, and showing that blood glutamine can actually go down in fasted people that are exercising. So, but of course, if you want the big hammer to happen fast, you would use a drug that would specifically target the glutamine. That would help so many people so fast. And why that's not available to us, but there are other glutamine drugs that you can look at. Now there's phenylbutyrate, which is a drug that was made for children with amino acid disorders. Okay, it was amino acid disorders. I have to excuse these phone. I can't figure out how to shut my telephone off. I've tried to choke it to death, but it's still, and there's all these, it's what it is everybody asking me for the kit, the metabolic therapy kit. Which I give to people, the idea here is does it work? How many people can live far longer with a higher quality of life if they incorporate metabolic therapy? My colleagues from Turkey have used standards of care, common chemo drugs, but at much lower concentrations when patients are in nutritional ketosis. So you can maintain the power of the drug and minimize the collateral toxicity to the body. So there's these hybrid approaches that work as well, as opposed to just doing, brute force metabolic therapy. But it works. I Brad and Maggie Jones, and now they're collecting dozens and dozens of these people that are all like stage 4 terminal. God, I don't know what they call terminal. I think we're all terminal to some extent. The problem is, like, who's going to check out faster than the other guy? The situation is, I don't know how many of these guys that was told you got 9 months, 10 months, 1 year, and they're all out there doing fine, smiling. Part of the evidence that we're accumulating that this stuff actually does work. But the problem is, how come there's no clinical trials on it? I mean, that's the biggest problem, and it's many reasons for that. First of all, if you go to your oncologist, you never heard of it, never been trained. So it's a system problem. It's the system is broken. There's a new path. There's a new way here to manage cancer without toxicity, and people react very, very against it because they should have known about it. They get angry or they never were trained, never heard of it. They continue to think glucose has no effect on tumors. They never heard of glutamine. I mean, you're dealing with a vast lack of knowledge that's so profound. Now, if I had a drug that could do what metabolic therapy could do, I'd be a multi-billionaire in about 3 weeks. The problem is nobody can figure out how to make any money on this stuff. I'm always looking, where is the entrepreneur? Will the entrepreneur please come forward? I don't know what to say. I mean, I get all these hot shots from Harvard University, all these business kids, they're always coming up saying, oh, this is like the most amazing thing. We can cure all these cancers with, or manage them, not cure them, with no toxicity. We're going to go out, we're going to build this. I never hear from them again. I don't know where they go. I mean, no, well, that's the whole thing. The only thing that can be made is longer life, overall survival and higher quality of life. Those are the outcome. Apparently it's not worthy of investment. That's the cutting edge right now. We're working on dosage, timing, and scheduling right now in my lab. And that's we need to know, and this is what we call non-sexy science. Okay, it's not sexy.
Yes.
Well, I mean, should I take it this much now or wait 2 days? And people say, well, this isn't exciting, but it's exciting when you live longer doing it. But for the field, this kind of research is not what the field thinks is academically exciting, unless you're the one with the cancer, and then you got to know dosage, timing, and scheduling is still the cutting edge right now. So when you say, oh, I know the drug I need, how often should I take it? What dosage should I take? And how should I take it? And we're suggesting that you take it when you're in nutritional ketosis with a glucose ketone index of 2.0 or below.
Yes.
Okay. And I tell you, many people have come to me and said, oh, I've done all this, I've done that, but I can't get my GKI down. I said, well, don't eat then. Just thing. It is true that if you were to take large doses of glutamine, you could potentially make your tumor grow faster. But that's why we have the drugs there. The drugs, the diet, yes, you're always going to have glutamine in the diet, and the body will make glutamine. So you have to have the drugs that will interfere with any kind of a situation. The thing about the carnivore diet is that it simply lets you get into the lower GKI faster. We saw it. We did it with a Mediterranean diet. We've seen it work. We've seen it work with the vegan. The problem with the vegan diet is there's a lot of carbs in the plants. You got to be chewing like a farm animal all day long. I mean, not to say that it doesn't work. It can. I mean, there are some people that feel they're going to go to hell if they eat a piece of meat. The idea is if those folks, they can do it as well. They just have to, they have to eat one string bean a day. I mean, we published a paper in bioarchives on Fenbendazole. And Fenbendazole and Mebendazole are very structurally similar. I really don't think there's going to be that much of a difference between the two. One of my colleagues said that Mebendazole might be better for brain cancer than colon cancer, whereas Fenbendazole might be the reverse. But I haven't tested them, but they're structurally very, very similar, and I suspect they would be equally effective. Yet why? The argument here is that how is it possible that a parasite, whether it's a dog dewormer or Mebendazole is used? My colleagues from India, when they were growing up, not everybody, many people have worms and stuff, and they were taking these parasite medications. And then, as we showed in our publication, the Mebendazole interferes with both the glucose and the glutamine pathways. So you'd say, well, how is that? What's the mechanism for that? And let me tell you, in our research, it turns out that parasites and tumor cells use a common pathway to get energy. So and so many of these folks on my comments on my YouTube videos, so many people think that cancer is a parasite. Cancer is not a parasite. Say that tumor cell use a common energy pathway. And the drug doesn't give a damn whether it's a parasite or a tumor cell. It targets a pathway common to these two organisms. Okay, these two cell problems. And the parasites, interestingly enough, they don't use the pathway when they're reproducing, but as soon as they stop reproducing and settle down in a particular tissue, they use that pathway. So that's why you take the fenbendazole to get rid of the parasites. It's uses an energy similar to a parasite, but it's not a parasite. It just happens to use a similar pathway. So these parasite drugs work really, really well. And sometimes cocktails of them work even better. Dosage that they were giving little children in India that had parasites was 200 milligrams a day for 3 days.
Yes.
Okay. And whether that's the absolute dosage and timing that we need and scheduling for what we need to do to kill cancer cells is not yet clear. This is where the medical industry, the oncology industry, should be jumping all over this to figure out what is the best dosage, timing, and scheduling for our cancer patients. They don't want to touch it with a 10-foot pole. Well, don't forget, that is not written in granite.
Okay.
It's we don't know. And if you look up Joe Tippins, who used fenbendazole for his lung cancer, he answered a lot of the questions that people were asking him. He did a particular routine in his case, and he was telling people that there's a lot of flexibility you have with these parasite medications. People will experiment on themselves to know how much they should take. This is the conundrum that you're experiencing right now. You and tens of thousands of other cancer people, is that there's no guidance. It's my way or the highway.
Yes.
There's no knowledge about how we're going to integrate metabolic oncology into the standard of care. And this is where each person is like their own experiment.
Yes.
And, when I was talking to Pablo Kelly today, he had experimented with certain foods that he thought might be good, and they backfired on him. And he went out of ketosis, and he had some breakthrough seizures and things like this. But he gets back on the track and can bring his body back into the zone. So, but again, patients should have guidelines. But the problem is these guidelines do not exist today.
Yes.
They're not there. What we are doing is simply showing the path that will be needed to effectively manage cancer without toxicity. The fine-tuning of the path will be the result of these kinds of trials on small groups of people at first, because we can't use the standard way clinical trials are designed. It has to be very different, because we're going to be mixing and matching. And then I spoke to some oncologists, and they said, it's impossible to do what you're saying, because we have to have rigid guidelines before we start a clinical trial. And we have to follow these guidelines, because then we won't know what works and doesn't work. And I said, what works is if the damn guy is alive 5 years longer than he should have been. I said, it doesn't take too many functional brain cells to know that something is working here. So it has to be a work. Oh no, we can't do that. It's not fit the rigid go. We have to throw that shit out. You're trying to keep people alive here, for crying out loud. You know what's not working. You know what can work if we adjust dosage, timing, and scheduling the right way with the guidance of knowledgeable people. Okay, how long will it take? I don't know. This is the problem. We have a clear plan for success. We're just not implementing it the way we should, and it's very frustrating.
It is.
I see all these poor guys suffering like incredible, dying, miserable deaths, poisoned and irradiated to the point where they're just a protoplasmic mass. This is tragedy beyond comprehension. And we have a plan and a path and scientific evidence to support a new way to manage cancer. And we can't break through the system to want to do that. So I don't know. But we're continuing to prove the science. That's all we can do. And get more and more Maggie Jones and Brad Jones patients like yourself and others, and just keep forcing these things. Because I'll tell you, you got cancer, you want to live. Most people want to live. And they're going to do whatever they can, but they go to their doctor thinking that he knows what's going on. 90% of the time, he has no clue. he has no knowledge about what's going on. He knows only what he's been trained to do. He doesn't know the biochemistry and the biology of the disorder that he's treating. And this is the tragedy. Why he didn't know that in medical school? Why wasn't this discussed with him when he went through the training process? Does he not know that glucose and glutamine are the only two fuels that can drive the dysregulated growth? I mean, this stuff is so solid, and yet they know nothing about it.
Yes.
Unbelievable. Unbelievable. The other thing that's really tragic with this situation is that these guys fear they're going to, if they do something outside the requirements, outside the standard of care, they could risk losing their license.
Yes.
Okay.
Yes. That's
so
the
there's
big
no
thing.
excitement.
So
there's no excitement to help you. I think you also have the option of doing twice a month at half the dose. So
at half the dose would be nice too.
You can talk to him about it. But the issue, of course, is that you're asking him to follow guidelines that are not recommended. That's where, and you have to ask him that. Are you going to lose your license if you do this? And if he says I could, then he's locked in. He's locked in. He can't make the implementation. That you might want to talk to Alicia Halakis from Minnesota. She runs a clinic there, and she's very, very good, and she understands the concepts, and she does a lot of good blood work on the patients. She's always following them very, very carefully. There's a free Libra device that you can attach to your arm that measures glucose all the time. Yeah, and I think there's in the works now, there may be a free Libra that can do glucose and glutamine simultaneously.
Yes,
sorry. Glucose and ketone bodies. Glucose and
that's
ketone.
right.
Yeah. So, and you can have it on your cell phone.
Yes.
So you can know when you're falling out. And then when you're on you can look, like when Dominic D'Agostino and I, years ago when we used hyperbaric oxygen, we felt that the patient or the mouse should be in the best therapeutic nutritional ketosis before they went into the hyperbaric chamber. So, so that the oxygen, the tumor cells will die from oxygen stress. So the hyperoxygen acts as radiation. It can kill the tumor cell by creating more ROS that only the tumor cells will die from, not the normal cells, which are protected by the ketone bodies. So again, this all depends on the time of the day when you have the singular best lowest GKI that you would either take Fenbendazole, Don, or hyperbaric oxygen, or any of these other supplements or procedures, all working together, and then exercise, and you put it all together, and you develop your routine for your situation to give you the best outcome, and so that you feel the best. But all this has to be recorded carefully. You have to be you're the pioneer here. You're the one knowing what your body is capable of doing and how well it responds to all this. So again, and you're working with the establishment to help you along as well.
Yes.
The problem is the establishment is not as flexible as we would like them to be. Press pulse. You have to realize that I adapted that from the field of paleobiology. It turns out that our Earth has gone through massive extinctions of organisms over the 4.5 billion years that this planet has existed to our knowledge. Okay. So we had tremendous numbers of organisms on the planet, and then some catastrophic events would happen. Massive amounts of earthquakes, shifting the environment. And what happens is you have chronic stress coupled with an acute trauma. And together, this led to the mass extinction of organisms. So I adapted the concept of press pulse from the field of paleobiology to stratify how we're going to mass kill cancer cells in the body through the same concept. You press down glucose with diets, and you pulse with drugs that will target the glutamine. And together, the tumor cells can't survive without those two fuels, and they can't transition to glucose or to ketones or fatty acids. So this is the strategy. It's beautiful. It's linked to all of the concepts that we understand in biology. So, and it can be used to manage and resolve cancers. It's just that we're not quite familiar with all the techniques and modifications that we need to perfect this strategy. That's where it is right now. I can't find them. In fact, I've offered a crisp $100 bill to my students to show me a tumor cell that can survive on fatty acids and ketone bodies in the absence of glucose and glutamine. And so far, I have not lost the $100 bill. And as a matter of fact, I've thrown it out to the entire cancer industry. So what happens? Let me tell you what happens.
Sure.
This is a little bit of a deeper dive now. Brace yourself.
Okay.
The fatty acids are known to be mitochondrial uncouplers. Okay. What that means is they uncouple the synthesis of ATP from oxygen. So oxygen, normal, we're breathing, all of us, you, me, Carrie, we're all breathing. Oxygen is the acceptor of electrons through the mitochondrial electron transport chain. So we can make ATP. ATP, adenosine triphosphate, is the chemical of energy. That's our energy source, adenosine triphosphate, made predominantly in the mitochondria through oxidative respiration, and that's why we're breathing. But there are some things that can uncouple, which means that the cell continues to take oxygen, but you've broken the link to make ATP. Okay, so in other words, it looks like the cell is breathing, but it's not making the energy. Now, what fatty acids can do is, and when the cell is uncoupled, it has to get energy, so it uses fermentation, which is glucose and glutamine. So what happens, sometimes fatty acids can make it look like it's driving the tumor growth. As long as glucose and glutamine are present in the air, in the microenvironment, the fatty acids will uncouple the mitochondria, forcing the cell to suck in more glucose and glutamine. And thereby, if they don't understand the biochemistry, they'll say, oh, tumor cells use fatty acids to grow. Yeah, as long as they have glucose and glutamine in the environment, that's possible. Yes. But if you take glucose and glutamine out of the environment, the fatty acid can't do anything because it can't be fermented, nor can the ketone body. So a lot of folks make this mistake because they don't understand the fundamental issues of the biochemistry and the biology of the problem. So yes, many people will say, oh, that tumor can burn, prostate cancer can use fatty acids. No, it can't. Show me the damn prostate cancer cells using fatty acids in the absence of glucose and glutamine. So no, we've looked into all of this stuff and we've tested it. We've interrogated all this. And the problem is the convention, the media, they try to do their best, but unfortunately the misinformation is so profound. And for the guy who doesn't know much, which includes the patient and the oncologist, you just get a whole bunch of crap that can't be interpreted. Oh, he said this. Oh, he said that. Oh, no, this cancer can do that. Cancer do that. Listen, we're testing all that. We can't find anybody. We can't find any tumor cell that can get energy through respiration sufficient enough to replace glucose. Glucose and glutamine are what we've seen is the weak link from all these tumors. So yes, I've tested fatty acids. No, fatty acids cannot replace glucose and glutamine for energy, nor can lactic acid. That's another one. Oh, tumors eat they crap out lactic acid. They don't use lactic acid for energy. So Corey, Saul and Gertie Corey got the Nobel Prize for their Corey cycle. And what they showed was that if you exercise vigorously, your muscles lose their ability to get enough energy from oxygen, and they start to ferment, producing lactic acid. The lactic acid goes to the liver, and the liver, two lactates are conjugated in the liver to a glucose molecule, which then comes back to the muscle. And you're right, the cancer cells, if they're throwing out massive amounts of lactic acid into the circulation, that lactic acid can go to the liver and come back to the tumor in the form of glucose. But if you're suppressing glucose while you're doing all this exercise, the probability of getting much back to the tumor is going to be minimal. So again, you have to understand the data that you collect from in vitro experiments, culture dish experiments, versus living animals and humans experiments. So you have to be able to distinguish and understand the differences between these two environments before you can fully understand the bigger picture of what's going on in cancer cells under these different conditions in different environments. I know it's a lot of stuff, but yeah, well, listen, I published a lot of this. A lot of this is already published in the scientific literature under my name, open access. So anybody that has a computer and Google can ask and go and get the Press Pulse paper that I wrote. Okay, you can get how cancer cells get energy. You can get the papers on how they metastasize. All of this stuff is out there, and it's very depth. And my book, the book that I wrote, has a lot of it in here. You know, I'm really surprised. I'm selling more copies of this book now than I did when it was first published. Unbelievable. So yeah, but the problem is you know, the biggest complaint is on this book, too expensive. You know, the John Wiley Press, they're in the textbook. They're one of the top scientific publishers. I mean, when it came out, it was $156 for this book. You know, everybody wants something for $19.99. Unfortunately, I had no control over the price of the book. But there's another book by, let me show you this one. You might want to look at this. Let me get it.
Okay.
This book here. This is an interesting book that was written by Angie Choi. You might want to speak to Angie.
Okay.
She had terminal cancer also, and she adapted the metabolic therapy, got really healthy, and then wrote the book. So,
Nice.
And she has how she did it. And I'm not saying what you do and what she did and what everybody's doing. J.J. Tracon, Flying High, he had terminal kidney cancer, and he did metabolic therapy, and now he's written a book on his experience. Pablo wants to write a book on his experience. Everybody who seems to survive terminal cancer wants to write a book on it. This is the biggest problem. I mean,
Yes.
we know we have a clear plan in the kit, and we're also writing a very comprehensive treatment protocol for this. So we got to get that published. You know, here's the tragedy. The change is going to come, in my mind, predominantly from the people, where the people come and say, where the hell can I get that? Why are you guys not knowing about this? Why are there's no practitioners that say, and be very cautious, because there's some people out there that are saying, oh, we're using Seyfried's metabolic protocol, and they're not.
Yes.
Okay. So, you know, I gave you the outline of what you need to do. If these folks aren't doing that, you steer clear of them. So yes. And the other thing, extremely important, we have made cancer to be 100 different diseases. The hospitals, Dana-Farber, MD Anderson, Sloan Kettering, they all claim that they have the experts for your specific cancer. All these cancers are very similar. They can't live without glucose and glutamine. So that's a shocker. And breast cancer, colon cancer, bladder cancer, brain cancer, lung cancer, we have found them all to have the same problem. They can't live without glucose and glutamine. So one of the things that could be done by those who are really interested, unite the tribes. We should not have breast cancer different from colon cancer, different from lung cancer. These guys are all the same. Unite the tribes. March on Washington. Tell the federal government that we have a plan to manage cancer non-toxically based on hard science. Why the hell are we not doing it? Get the breast cancer people. But the problem is when you go to pink ribbons and breast cancer, you know, the Susan Komen Foundation is in bed with the pharmaceutical companies. So the people have to unite. It's got to be the people themselves that have to unite, and to unite around one common problem: cancer. It can't live without glucose and glutamine, can't burn fatty acids and ketone bodies. We have a clear path to manage this disorder. The problem is the information is so fragmented and separated, and the misinformation and all this kind of stuff that's going on. Even the federal government's page on the National Cancer Institute says cancer is a genetic disease. I mean, nothing could be further from the truth. So even the federal government, our so-called leaders in the field, seem to not understand this. Or if they understand it, they can't challenge the problem because the system is so locked into what we're doing now as part of the standard of care. That has to be either modified significantly or removed. Get out of the way. If it's not going to be part of the solution, get out of the way. Yeah, well, you can always ask them. And, you know, you have the people who are raising money and they're going to cancer research. What kind of research are you talking about?
Yes.
You know, what kind of funding are you giving? Is it metabolic? No, they mostly, I don't know where it's going. In fact, there's no accountability. That's another thing. there's no accountability. If we're investing millions and millions of dollars into a problem and we get worse and worse outcomes, what the hell? I mean, this is like nuts. I mean, when you say, "Oh, I feel good about donating $100 to the Colon Cancer Foundation," well, how come all these people are getting colon cancer? There's no accountability where all the money's going. People feel good, and then they're going to go out and run and exercise, and that's good. That helps them. You're going to benefit more from running for the foundation than giving the money to the foundation. That's terrible.
Absolutely.
I mean, all this stuff is like nuts when you realize, how many different programs are just like screwed up doing all this stuff. But, I track down for the different foundations. I look at the scientific advisory committee for the different foundations. And I go and I said, okay, who's on the scientific advisory committee? And you look at the names, they have to say it. It's a public foundation. So they got to say this doctor. So then you just go into PubMed and you ask, what are the papers they're publishing? What kind of research are they publishing? And you find out they're all doing stuff related to the somatic mutation theory. They're not. So you might as well take your money and flush it down the drain. President Obama's, when he was vice president, he had the Moonshot Project, and now as a president, he's pushing the Moonshot. This is mostly for immunotherapies. Okay, That's the new hot thing. Keytruda, Opdivo, all this stuff. It's all based on the somatic mutation theory. So it might help a few folks, but it's not going to be the solution to the problem. That's $100 million investment in that organization. Yes. So and now breast cancer has replaced heart disease as the number one killer of women over 40 years of age. And we're dumping millions and millions of dollars into this breast cancer stuff. And nobody seems to ask, where the hell's all this money going? How come there's no improvement in anything? They're not asking the right questions because the theory under which they're treating the cancer is incorrect. And that explains the majority of it.